Yeah, you can start after 30 seconds.
Yeah. Okay. Awesome.
Good evening and a warm welcome to one and all for the Thyroid Clinic session. We are thrilled to have you today for an informative session on thyroid health. So, before we start today's session, there will be a brief video on the Indian Thyroid Society, which represents the society's mission, the current efforts, and the influence it has in achieving the advancing in thyroid health. So, I request the tech team to please play the video.
तस्य भास सर्वमिदं विभाति
So the Thyroid Clinics is being currently led by distinguished coordinators, Dr. Pramila Kalra Madam and Dr. Roma Pradhan Madam. So Dr. Krishna Sheshadri sir, who is the president of ITS, Dr. Arun Menon sir, the secretary, Dr. Mini ma'am, who is the treasurer, contributions, they are immense in conducting the program. We are also joined by the Thyroid Clinics team, Dr. Chitra and Dr. Vijay Reddy sir. So together we aim to provide the most up-to-date insights in thyroid care. So, another short announcement before we proceed. So, those who are interested to submit their research on our flagship journal, that is the Thyroid Research in Practice, can simply do so by scanning the QR code displayed on the screen. So, those who are interested to become a reviewer for the Thyroid Research in Practice, again, can simply scan the QR code, which will help you sign up as a reviewer. So we'll just go through today's program's overview. So our session will include a case presentation, which is presented by Dr. P.L. Srinivasan, who is the senior resident in the Department of Endocrinology, Madurai Medical College. The case discussion will be moderated by Dr. S. Sridhar sir and Dr. Rajneesh Mittal sir. Following this, we have an interesting talk by Dr. Prashant Jia sir, who will deliver a talk on the role of nuclear imaging and therapeutics in the management of DTC, followed by an engaging quiz by Dr. Harshita at about 8:50 p.m. So moving forward, I'd like to invite Dr. Vijay sir to introduce the moderators for the case discussion.
Good evening to all. Welcome to today's session of the Thyroid Clinics. Today, we will start off with an interesting case, a rare case of thyroid malignancy with a beacon of hope. I think as soon as we hear the word malignancy, the patient starts getting jittery. And with regard to thyroid malignancy, we should explain that most often the outcomes are good if detected early. And today we are going to see one such rare thyroid malignancy with a good beacon of hope. So to present this case, we have Dr. Srinivasan, who is second year DM resident at Madurai Medical College. And the session will be moderated by Dr. S. Sridhar, who is Professor and Head Department of Endocrinology, Madurai Medical College, Madurai, and Dr. Rajneesh Mittal, Senior Consultant Endocrinologist at Mittal Super Specialty Hospital, Yamunanagar, Haryana. So Dr. Sridhar is currently Professor and Head Department of Endocrinology and Metabolism, Madurai Medical College. He is also a visiting consultant at Vadamalayan Hospital, Madurai. He has done his DM Endocrinology from PGI Chandigarh and MD Medicine from JIPMER, Puducherry. He was awarded Best Outgoing Student in MD at JIPMER in 2008. And he has also got the ESI TISA Award and the A.V. Gandhi Award at national level winner in 2012. And he was recently got the ESI President Appreciation Award 2023 for ESI Registry Initiation. Welcome, Dr. Sridhar. The session will also be co-moderated by Dr. Rajneesh Mittal, who is Senior Consultant Endocrinologist, Mittal Super Specialty Hospital, Yamunanagar, Haryana. He has done MD Endocrinology from MS Ramaya Medical College, and is invited faculty for regional and national conferences and a reviewer for several national and international journals. Thank you. With this, I welcome Dr. Srinivasan to present the case on the interesting case of thyroid cancer with beacon of hope. This will be followed by the monologue on role of nuclear imaging and therapeutics in differentiated thyroid cancer DTC by Dr. Prashant Jia. Over to Dr.
Yes.
Srinivasan.
Thank you, sir. Are my slides visible, sir?
Yeah, it's visible.
Yes.
So, a very good evening, respected faculties. Today, I'm here to present a rare case of thyroid malignancy. So, 73-year-old female patient who came with the chief complaint of swelling in front of the neck for the past 1 year. So, history of presenting illness. Patient was apparently asymptomatic 1 year back. Noticed swelling in front right side of the neck. The swelling initially had an insidious onset, around 4 to 2 centimeter size, with no appreciable change over the last 9 months. However, over the last 3 months, the swelling was undergone a noticeable increase in size, almost involving a significant portion of the right side of the neck. This was associated with history of difficulty in swallowing both in liquids and solids for last 3 months. Also, she had associated recent voice change over the last 3 months. There was no associated pain at any point of time. So she had no history of difficulty in breathing, no history of any other swelling in the neck, no history of facial puffiness or facial congestion, no history of hypo or hyperthyroidism, no history of loss of weight and loss of appetite, no history of any bony pain or bony swelling, no history of chest discomfort, no history of constitutional symptoms like fever and night sweats. So past history, patient did not have any history of any thyroid disorder in the past. Also, she didn't history of any radiation to the neck in the past. Also, did not have any other comorbid illness. Also, didn't history of any other chronic drug intake. So, personal history unremarkable. Family history, she had no history of thyroid disorders in family members. And additionally, she had no history of malignancy in family as well. So, examination, she was conscious and oriented at the time of examination with the BMI of 20 kg, afebrile at the time of examination. She did not have any pallor, ictus, cyanosis, clubbing, or pedal edema. Clinically, she had no signs of hyperthyroidism. Also, no eye signs were noticed. She had mild hoarseness of voice. Neck veins on examination were not engulfed. Both pulse rate and blood pressure are within normal limits. So, inspection, sitting position with neck extended. A single swelling, almost a ovoid shape, was noticed for the anterior and the right side of the neck, with approximate size of 8 to 6 centimeter, which had well-defined margins and a smooth surface. Superiorly, the extent of the swelling is 6 cm below the mandible. Inferiorly, 2 cm above the sternal notch. Laterally, it extends from the anterior border of the right sternocleidomastoid muscle. Immediately, it extends plus 1 cm lateral to the midline. So, lower border was visible on examination. On examination, swelling was moving in degradation, but not with protrusion of tongue. So, additionally, no skin changes, scar signs, fistula are noted. Pemberton sign was negative. Also, additionally, no engulfed veins are noted over the neck. Also, no venous prominence were noted over the chest wall. No visible pulsations were seen. So, palpation, all the inspectory findings of extension were confirmed. On palpation, no warmth or tenderness over the swelling was noted. The swelling of approximately 18 to 6 centimeter size, palpable on the anterolateral aspect of the right side of the neck, extending just from the cricoid cartilage to just above the suprasternal stars was noted. The swelling was hard in consistency. It had smooth surface, regular margin, and was mobile on both horizontal and vertical assessment. The lower border was palpable. Additionally, the skin over the swelling was pinchable. Also, no pulsation or thrill was seen over the swelling. So, right carotid pulsations are relatively weak when compared to the left carotid, which was normal position and volume. So, trachea was in midline on examination, and Koch's test did not precipitate any stridor and was negative. Also, additionally, patient had no lymph nodes and palpation. So, percussion revealed no retrosternal distress. Auscultation, no bruit was audible. So, systemic examination was unremarkable. So, summarizing the case, elderly patient with the anterior aspect, that is the anterior aspect next swelling, that is the right salter goiter of almost 1 year with rapid increase in size for the last 3 months. Additionally, with compressive symptoms, clinically euthyroid with no lymphadenopathy in examination. So, correlating all the findings, differential diagnosis, first will be thyroid malignancy, top priority will be anaplastic carcinoma, considering the age and the rapid growth of the tumor, followed by follicular carcinoma and papillary carcinoma. And also, secondarily, a rarer possibility of hemorrhage into a benign swelling like a thyroid adenoma. Also, a further rarer possibility is a malignant transcription of Hashimoto's thyroiditis into papillary carcinoma of thyroid or thyroid lymphoma.
What is the possibilities of this case may not be a thyroid malignancy? What is the point favor? What is the point against it till the clinical history as well as the clinical examination?
Points in favor of malignancy include age of the
Go back one slide, that previous slide. Yeah.
So points in favor of malignancy is mainly the age of the patient, sir. Also, rapid increase in size of the swelling. These are the 2 points favoring malignancy. Also, on examination, the swelling was hard in consistency. So, these 3 are main favorable factors. Although swelling size is more than 4 centimeter, any size more than 4 centimeter is more of malignancy in an elderly patient. So, against malignancy is mainly that no lymphadenopathy was seen in the patient. So that is the one that is major against malignancy. Also, in constitutional symptoms, mostly patient will be having loss of appetite and loss of weight. That was not present in this patient.
And palpatory finding, what are the things that is against malignancy?
Against malignancy is mobile swelling. Most of the malignancy is hard and fixed in case of advanced stages in elderly patients. The swelling is mobile, that is against malignancy, sir. Also, regular margin is against malignancy. Most of the malignancies tend to have an irregular margin.
The skin over the swelling, that also.
Skin over the swelling is pinchable since it's an early stage of malignancy. Advanced stage of malignancy is usually not pinchable, sir, but most of the time it's not pinchable skin over the swelling.
Dr. Rajnish, you want to ask any?
No, Dr. Sridhar, I think we'll move.
Okay, yeah.
So coming to the investigations, all routine investigations were within normal limits. Thyroid function test, she had normal T4 levels with elevated anti-TPO suggestive of an underlying thyroid autoimmunity. So ultrasound neck revealed a solid, markedly hypoequiation involving both lobes of thyroid isthmus as a whole, measuring 8 into 6 into 5 centimeter. So the margins were irregular and lobulated, and increased central vascularity, that is increased vascularity within the mass was noted. So both lobes of thyroid and isthmus could not be distinctly visualized. So ultrasound also revealed that there was no any abnormal lymph nodes. So carotid vessels, when compared to the left side, on the right side, were a little bit compressed. So overall, it was of thyroid spy grading. Then he had gone for an FNEC thyroid, which showed a cellular smear showing diffuse sheets and clusters of both small and large lymphoid cells with scanty thyroid follicular epithelial cells and absent colloid. So the FNAC aroused the possibility of lymphoma thyroid or on Hashimoto's thyroiditis.
Yeah, go ahead.
So next we have gone for a true cut biopsy, which revealed a monomorphic population of sheets of abundant sheets of small to medium size lymphoid cells. Also, thyroid cells infiltrating the thyroid follicular cells are infiltrated with the lymphoid cells. Also, some amount of prominent germinal centers are seen in the biopsy.
Just go back, Dr. Srinivasan.
Yes.
Yeah, one slide more. So I just wanted to know one slide more. Yeah, here, when we have done ultrasound, so one point is that we didn't see any lymph node, right?
Sir?
We didn't see any lymph node here.
Yes, sir.
Yeah, and second, we are seeing a big mass involving
Yes, sir.
both right and left lobe. So is
Yes.
it a mass separate from the thyroid gland, like a nodule, or it's basically the thyroid gland itself, which is a big mass-like lesion and size is increased, which has become vascular. So are you able to delineate normal thyroid tissue and this nodule, or this whole is a thyroid mass or a separate nodule?
Sir, it's almost involving whole of the thyroid. Probably it's
So
whole of it.
basically, you want to say that probably it is just a goiter, isn't it? You want to say like that, which has become vascular, but the margins are irregular, lobulated.
Yes, sir.
So Yeah, it has to be basically, when we are seeing irregular lobulated margins, increased vascularity. So mostly this is a mass within the thyroid gland.
Yes,
Okay, but it is impinging probably on the thyroid
sir.
normal capsule, and probably, that has already undergone destruction where
Yes,
we are not able to see the normal thyroid tissue radiologically.
yes, sir.
And second thing is that you have done FNAC in this patient where we do see some lymphoid cells. Now the question is that do we really subject every patient to biopsy? Because generally, traditionally, when we see patients with nodules, we do an FNAC and then we plan the further management of the thyroid patients without doing biopsy.
Yes, sir.
But in this patient, you have done a biopsy of the patient after doing a FNAC of the thyroid gland. So what are the points that actually you would like to delineate where you have to do a biopsy in a patient of FNAC? And what are those findings which makes you suspicious that this patient should undergo biopsy to confirm the diagnosis?
First, if FNAC is mm, showing any atypical cells, necrosis, that is an indication for biopsy. So sometimes in case of abundant population of lymphoid cells, thyroid lymphoma can be a possibility. That is also an indication for through-cut biopsy. So in case of
So,
follicular lesion, we with FNAC we usually cannot differentiate between benign and malignancy. So in that case, we have to ideally go for also biopsy in case of FNAC.
okay, so basically the message is that if you see the lymphoid cells, you want to say that for every, if we see a lymphoid cell, we have to go for a biopsy of the thyroid gland or the nodule, basically. If you see lymphoid tissue in the FNAC.
No, no, sir.
Any
It's a
any specific
abundant population
markers?
of monomorphic lymphoid cells, sir.
Right.
Predominantly, if we see lymphoid cells, definitely we have to go for a true cut or core biopsy.
Yeah, any specific markers we could have had used in FNAC tissue itself to clinch our diagnosis?
Sir, immunohistochemistry for B cell and T cell markers
Hmm.
that would have
Okay,
been helpful.
okay, go ahead.
So coming to the immunohistochemistry was positive for PAX5, CD20, and BCL2, confirming the cells of B cell origin. Also, BCL6 was negative, and CD23, which is also a B cell marker, was focal positive. So Ka67 proliferation index was in the low to moderate range of around 20 to 30%. So the overall findings were suggestive of an B cell non-Hodgkin thyroid lymphoma, possibly a mucosal, that is a mild type of non-Hodgkin lymphoma.
So did you do
So
LDH levels after you got the biopsy done for
yes,
the
the LDH
patient?
levels for this patient was in high normal range, around 260 international units per liter, not much that much massively elevated.
Okay. And B symptoms were negative.
B symptoms were negative.
Okay.
So
Yeah, please
for
go ahead.
further staging, we have undergone an 18 FDG PET scan, which revealed an enlarged thyroid of around 7 into 5 into 7, 7 millimeter, with a SUV max of 12. So minimal retropharyngeal retrotracheal extension was found on the right side. So no evidence of any extrathecal extension was seen. Also, no bone marrow involvement was not there, and no other FDG with skeletal metastatic lesions were noted. So final diagnosis, the case of primary thyroid B cell non-Hodgkin lymphoma, probably indolent stage of mild lymphoma in early stages like stage 1E. So regarding the treatment, after consultation with the medical and radiation oncologist, they suggested radiotherapy. So the patient was subjected to an external beam radiation therapy, that is 3D CRT, 24 gray and 12 fractals. So on follow-up, the thyroid gland size significantly reduced. Also, repeat FDG at 6 months revealed a significant reduction in metabolic activity in thyroid gland. So currently, patient is under 10 months follow-up, which is uneven.
So if there were nodules in this patient, let's say like that, and then could you have had, been able to differentiate between primary thyroid lymphoma or secondary thyroid lymphoma? And would that have changed the management protocol for this patient and prognosis also?
Uh, Regarding secondary lymphoma, patient will be having other areas lymph node involvement. So initially, presentation of constitutional symptoms will be there. Sir. So also, patient will be having lymph node elsewhere involvement.
Yeah, suppose there were cervical lymph nodes for this
Yes.
patient. There were cervical
Cervical,
lymph nodes.
it's
Then it extended to thyroid, like it became secondary thyroid lymphoma, right?
yes, sir.
Yeah, yeah. So will the management be different in both of these patients? And can you differentiate between these two, whether it's primary or secondary?
Regarding differentiation, starting from the clinically, primary thyroid lymphoma arises in the background of Hashimoto's thyroiditis. Secondary, mostly patient will not be having in background.
Regarding the management, because if you are labeling someone is a primary thyroid lymphoma as well as the secondary thyroid lymphoma, so how the management differs? Question.
Management for a primary thyroid lymphoma, particularly mount lymphoma, radiation is radiotherapy is sufficient in most cases. Whereas in case of an secondary mount lymphoma, we have to go for a combined chemo radiotherapy. That will be essential.
And the systemic therapy. So, what is the ideal systemic therapy it is recommended for lymphoma or chemotherapy?
The ideal regimens, R-CHOP regimens, R-CHOP regimens.
Because already there's all secondaries, they will be having systemic involvement. So, we have to completely remove all the seeding cells throughout the system. Whereas this is like locally invasive or predominantly restricted to the thyroid gland. Okay.
Any role of surgery in any lymphomas where surgery is corrective? Thyroid lymphoma, where surgery is a corrective treatment for those patients.
Thyroid lymphoma, in early mount lymphoma, in certain papers they have suggested surgery is initial mode of management, sir. Since mount lymphoma is also executively radiation sensitive, so radiation therapy is a mode of treatment. So patient is not willing for any radiotherapy. In case of internal mount lymphoma, we can go for surgery which has an curative role, sir, but
Right.
not
So,
widely followed actually.
yeah, many a time it is incidentally detected, like patient undergone lobectomy and it turns out to be intrathyroidal malt lymphomas.
Yes.
Yeah, go ahead.
So coming to the discussion part, so any patient with rapid enlargement of thyroid, the acute settings, so acute infectious thyroiditis and subacute thyroiditis are common differential diagnosis. Also, a hemorrhage of thyroidedema, hemorrhage into thyroidedema, cyst is also a possibility. In case of elderly patients, anaplastic thyroid carcinoma is always a possibility. So in case of middle-aged females, infiltrated thyroid disorder like radial thyroiditis can also be a possibility. And lastly, thyroid lymphoma, especially in a patient with Hashimoto's thyroiditis. So coming to thyroid lymphoma, it's classified as primary and secondary thyroid lymphoma. So primary thyroid lymphoma account for 1 to 5% of all thyroid malignancies. It usually affects the thyroid gland first, followed by lymph nodes and other organs. Mainly women are affected at around the age group of 65 years. So pre-existing Hashimoto's is the associated only risk factor. So normally thyroid gland doesn't have a lymphocyte. So in the background of Hashimoto's thyroiditis, there is an amount of chronic antigenic stimulation, which results in the formation of intrathyroid lymphoid tissue and ultimately leading to the formation of a non-Hodgkin lymphoma. The two major varieties of primary thyroid lymphoma include diffuse large BCL and marked lymphoma. Overall, DLBCL is the commonest cause of primary thyroid lymphoma, and it is more aggressive. And the treatment also differs. DLBCL, we have to go for a combined chemoradiation therapy, and 5-year disease-specific survival rate is less when compared to marked lymphoma. Whereas on the other hand, a marked lymphoma is less aggressive and indolent in most of the patients. So localized in the so the radiation therapy in initial stages will suffice in most cases. So 5-year survival rate is more than 90% case of marked lymphoma.
Can you see even a patient with Graves' disease with lymphoma, like Graves' disease is also an autoimmune disease.
Yes, sir.
So since we know that pathogenesis is autoimmune chronic antigenic stimulation, can you really see Graves' disease also with the thyroid lymphomas?
As per literature, 1 or 2 cases have been reported, sir, but Hashimoto's is a predominantly Th1 inflammatory response. So Graves is a Th2 inflammatory response. So that is a major driving force behind the primary thyroid lymphoma. Also, the cytokine profile is different in Graves when compared to Hashimoto. So that is the two major differences in the driving force of primary thyroid lymphoma among both the etiologies.
But still, rarely it can be
It can
associated
happen.
with Graves as well.
Graves.
Yeah.
So coming to the ultrasonographic pattern of primary thyroid lymphoma, nodular, diffuse, and mixed. Overall, nodular type is most common. It's most commonly present in well-defined hypoechoic mass. So ultrasonography is usually useful for narrowing down from other thyroid malignancies. When compared to Hashimoto, high central blood flow with high resistance is usually seen in case of primary thyroid lymphoma. For differentiating from anaplastic carcinoma, internal lean echogenic expanding with posterior acoustic enhancement differentiated from anaplastic carcinoma. So diagnostic modalities, FNA and core biopsy are widely used. Also, FNA alone has low sensitivity, but diagnostic in patients with a large burden of a lymphoma. Core biopsy is the gold standard along with immunohistochemistry. So also many literature papers are available in which FNAC itself diagnosed primary thyroid lymphoma. So the rates of positivity in primary in FNAC ranges from 65 to 90%. So whenever the FNAC shows predominantly lymphocytes, PTL should be considered. Also, a mixture of small and large lymphocytes, it's always suggests of primary thyroid lymphoma when compared to Hashimoto's thyroiditis. So treatment, in case of mild lymphoma, since it is indolent and localized, radiotherapy will be sufficient. Whereas combined chemoradiotherapy is treatment of choice in advanced stages of both mild and DLBCL. So radiotherapy alone can control the disease in high percentage of disease limited to thyroid. Surgery, currently it is not an indication for primary thyroid lymphoma. So the role of surgery in today's world is to obtain tissue for histopathological diagnosis and also some palliative debulking procedure for those with an compromised airway. So overall, R-CHOP is a preferred regimen for both types of lymphoma. So concluding, primary thyroid lymphoma is a rare neoplasm accounting for almost 2% of all thyroid malignancies. So it should be suspected in all patients who present with the rapidly enlarging neck mass, especially in the background of an Hashimoto's thyroiditis. So histopathological evaluation supplemented by IHC is a gold standard for diagnosis, though FNAC is diagnostic in most cases. So poor prognostic factors is size more than 10 centimeter, stage greater than 1E, presence of obstructive symptoms, mediastinal involvement, age more than 60 years, elevated LDH and beta 2 microglobulin levels. So with regards to treatment, combined chemoradiation therapy appears to be the best treatment modality overall. Thank you.
Dr. Srinivasan, very good case, excellent presentation. Just a last question from my side. Like if treatment fails, there is a treatment failure or there is a relapse of the disease in such cases, what are the options for the treatment?
Options is again, we have to go for chemo and radiotherapy, sir.
So you have to
If
repeat the
R-CHOP
cycle of R-CHOP, yeah.
Repeat cycle of R-CHOP. Recently, GEMOX and MINDS, ESNA, 3-year regimens have been validated in literature.
Right. Thank you. Over to Dr. Sridhar.
Good evening, everyone. I just want to clarify one thing for the biopsy thing. So biopsy we do basically to differentiate between anaplastic and lymphoma. And as mentioned by you, follicular lesions, we do not do biopsy in those cases because in biopsy also we cannot make out whether they are benign or malignant because we need the entire specimen, the capsule, to see the capsular invasion to.
Okay, ma'am.
Dr. Sridhar.
Yeah, I think this case biopsy predominantly to avoid surgery or to confirm the lymphoma. Otherwise, we also
Yeah, that's what. Because he mentioned follicular lesion. That's why I just want to clarify for him. No biopsy for follicular lesion. That is.
That's good.
What are the immunophenotypes that will be helpful apart from this already Dr. Srinivasan? Immunophenotype to differentiate between this MALT as well as the diffuse large B-cell lymphoma.
Sir, main thing is Ka67 proliferation factor. Ka67 in case of DLBCL will be very high, around 80 to 60 to 80%. Whereas it will be very low in case of myeloma. That is the main differentiating feature with respect to immunohistochemistry.
Now the question is open for discussion.
I think I just have to make one observation. Similar to this scenario, where thyroid cells, thyroid tissue doesn't have lymphocytes, so only on a background of Hashimoto's you get this thyroid lymphoma. Similarly, in adrenal gland also you have this primary adrenal lymphoma. where there are no lymphocytes in the adrenal, and then you can have this adrenal lymphomas on a background of autoimmune adrenalitis. Those are also required.
If no more question is there, I think I thank the ITS team for given this opportunity to present this interesting case.
Just
Thank you.
tech team, any questions are there from the audience? Can you just check once?
No, ma'am. As of now, no. Yeah, we can carry on. Everybody said good that and all appreciation.
Okay, thank you.
Thank you, Dr. Srinivasan, for such an engaging and informative case presentation. Special thanks to Dr. Sridhar sir and Dr. Rajneesh sir for their valuable insights and moderation. So next, I request Dr. Vijay sir to introduce our guest speaker for the next session, Dr. Prashant.
Thank you.
Next, we move on to the interesting topic of role of nuclear imaging and therapeutics in differentiated thyroid cancer (DTC). And to talk on this case, we have Dr. Prashant GR. He's consultant nuclear medicine and PET CT at HCG Hospitals, Bengaluru. And he is having extensive experience in routine conventional nuclear medicine procedures and PET CT procedures and radionuclide therapies. And he'll be the right person to highlight on this important role of nuclear imaging and therapeutics in DTC. And we all know that this is an important area where nuclear medicine and therapeutics help us in management of DTC. Over to Dr. Prashant, sir.
Hello, very good evening to all of you.
Tech team, I think you can stop sharing your screen.
Can I start?
Yes, sir.
Yes, sir. You can screen share, sir. Yeah.
I've shared my screen. Hope everyone can see it.
No, sir, we are not able to see the screen as of now.
Try sharing the screen once again, sir, please. Yeah.
Okay.
Now it's coming. Yeah. Yes, sir. We are able to see, sir.
Okay.
Awesome.
Yeah. A very good evening to all of you. So my name is Dr. Prashant. I'm a consultant in nuclear medicine in HCG Bangalore. And today I've been asked to speak about the role of nuclear imaging and therapeutics in differentiated thyroid carcinoma. Okay. So thyroid carcinomas of follicular origin are broadly differentiated, well-differentiated, poorly differentiated, and undifferentiated. Nuclear medicine has had a role predominantly in this well-differentiated variant only. But however, with progression of disease, we have seen that this well-differentiated also tends to become de-differentiated, become more aggressive. So the later part of my talk would be more related to how to image these and how we could come into treatment of these de-differentiated or poorly differentiated and undifferentiated variants also. So the main difference between the differentiated and undifferentiated thyroid carcinomas being mainly thyroglobulin production, iodide uptake, and expression of TSH receptor. And they differ from undifferentiated variants being that they are very slow growing and they do not metastasize early. So these are basically favorable indicators. So iodine-131 therapy, as we all know, is recommended for carcinoma thyroid treatment. This is after total thyroidectomy. Papillary, follicular, mixed papillary and follicular variants are what we are treating with radioiodine. And in our country, iodine-131 is the only isotope that is available, which is used for diagnosis as well as therapy. The current consensus for treatment of differentiated thyroid carcinoma has been prompt and near total thyroidectomy. The reason being that the avidity of the native thyroid gland is about 50 to 100 times more for iodine than malignancy. So the presence of a significant amount of residual thyroid tissue would impair the uptake of the neoplastic tissue there. So which would be of no use for the patient. Next, withholding of thyroid hormone for about 4 to 6 weeks. Identification of the functional thyroid tissue using iodine 131, wherein about 2 to 3 millicuries of iodine is given orally for a patient, and the scan is performed typically about 24 hours later. Then, once the scan has been done, once a residual thyroid tissue or metastasis has been demonstrated, then these patients are treated with radioiodine in a larger quantity. So once these people are admitted, they would require admission and isolation for about 2 to 3 days in isolation room, as recommended by the Atomic Energy Regulatory Board for radiation safety purposes. So in 2 to 3 days, they've become fit enough to be discharged. Their radiation levels come down to suitable levels wherein they are discharged from our center. Long-term thyroxine treatment is what these patients will be on. And typically follow-up will be after about 6 months with a large dose iodine scan and serial thyroglobulin estimations. So like I told you, why we require a near total or a total thyroidectomy? Because any native thyroid tissue will impair iodine uptake by the malignancy. And what we always ask our referring physicians to remember is, if any imaging is required, please avoid CT contrast, because CT contrast is iodinated and it can interfere with the subsequent diagnosis and treatment of these patients for weeks to months. So if at all any imaging is to be considered, please consider MR or MR with contrast. And for all your patients, we do ask them to be on a low iodine diet. Thyroxine, we are stopping for about 4 to 6 weeks if the patient is on follow-up, or after surgery, typically it will be about 3 to 4 weeks. We want the TSH to be more than 30. And once we give iodine, we do the scan. These are the few factors which can affect the morbidity and mortality of patients negatively, mainly being male sex, age more than 40 to 50, metastatic or local invasion at presentation, inadequate initial surgery, no prior iodine therapy, no thyroid hormone therapy after surgery, delayed initial treatment, or the presence of biological variants like tall cell insular variants and all that. So now coming to the role of TSH in the management of thyroid cancer. So what happens is iodine uptake by sodium iodide importers is dependent on the stimulation by TSH, both in normal and cancerous thyroid cells. Higher stimulation is required for adequate uptake by the residual or metastatic differentiated thyroid carcinoma. And typical values that are recommended are anything more than 30 international units per ml. Peak stimulations have been seen to be around 50 to 80 micro-international units per ml. So how do we use a TSH for a patient? One, by endogenous stimulus, wherein the patient is off L-troxin for about 3 to 4 weeks, or a patient is not put on thyroid hormone replacement for about 3 to 4 weeks. These patients experience hypothyroid symptoms, which are sometimes severe. The other way around for this would be using recombinant TSH, which is readily available. However, this is extremely expensive. It costs around 1 lakh, which most of our patients would have difficulty using. So we do use recombinant TSH on a few patients only. The advantage here being the patient is on T4, so no uncomfortable symptoms of hypothyroidism for your patients. So what happens when you give recombinant TSH is demonstrated in this graph here, wherein with stopping L-troxin, typically the TSH values go up to around 40 by around the 4th to 5th weeks. Whereas when you give recombinant TSH in a span of 2 days, recombinant TSH is given on 2 consecutive days. So TSH levels go up to around 200 international units. So advantage being we can achieve very high levels of TSH and shorter duration of stimulus for the tumor. These are a few other investigations that are recommended for your patients, and typical doses would be as follows. It can vary from center to center, but typically these are the doses that are administered to your patient for treatment with radioiodine. So the objective for iodine 131 scan or therapy in patients who undergone surgery for differentiated thyroid carcinoma would be remnant ablation, basically to eliminate normal tissue to facilitate detection of recurrent disease and initial staging, as an adjuvant therapy to decrease the risk of recurrence and disease-specific mortality by destroying suspected but unproved metastatic disease. And third, basically for therapy to treat known persistent disease. So whenever we give radioiodine, we perform a scan, subsequently we treat, and after therapy, we'd be doing a post-therapy scan. So in a large dose iodine scan, we do tend to see residual thyroid tissue immediately after surgery, in a few patients, metastatic nodes, and in the presence of metastasis, metastatic disease also, as in this patient, we are seeing bilateral lung mets. So once treated, when the patient is fit for discharge, we do a post-therapy scan also. The reason being, for a thyroid scan, I would have given us a very small dose of radioiodine. And for therapy, I would be giving at least about 50 to 100 times the dose required for diagnostic scan. So I do tend to demonstrate more metastasis if they are around. So as in this patient, we can see a few more cervical nodes, which were not seen initially on the diagnostic scan. So ablation of residual thyroid gland is favored because it allows accurate diagnosis. It allows accurate diagnosis with iodine 131 scan for recurrences or metastasis. It allows accurate monitoring with thyroglobulin, reduces local recurrence and later metastasis in case of multifocal thyroid carcinoma. This graph demonstrates the benefit of treating patients with radioiodine, wherein once a patient has been treated with radioiodine, the cumulative recurrences are less than 10% at between 20 and 35 years. Whereas a patient who has not undergone radioiodine therapy, local recurrences are pretty high, more than around 30 to 45% over a span of 20 to 35 years. And the advantage here being, once you've ablated the residual thyroid tissue, thyroglobulin can be used as a marker. So any subsequent jumps in thyroglobulin values gives you an early indication as to the to look for any metastasis or to look for any dedifferentiation. And whenever histopathological values are not, when your histopathology report is not all that conclusive, then a radioiodine scan is also extremely helpful, as in this patient whose histopathology did not definitely say it was malignancy. So either way, the patient had come to us for a iodine scan. So what did we see? Not only did we demonstrate a residual thyroid tissue here and neck, patient had bilateral lung metastasis. Thyroglobulin was also sky high. So indirectly, we went ahead and told that this was carcinoma thyroid, this was metastatic carcinoma thyroid, and subsequently patient underwent radioiodine therapy. So among differentiated thyroid carcinomas, what has been seen is about 30% of these will develop metastatic disease in the locoregional lymph nodes. And the 5-year survival rate is pretty good, more than 90%. And very rarely, these people develop metastasis in distant organs with a significantly worse prognosis. The 5-year survival typically would be around 55%. And of late, we do tend to see that there is an increase in overall mortality of these patients, probably because we are seeing more metastatic disease. And what we have seen is that these patients will continue to exhibit iodine 131 avidity. So that is the reason these patients will undergo repeated I-131 therapy. And the subsequent to therapy, these patients are put on thyroid hormone replacement so that again we can treat them at follow-up. So as long as the disease remains iodine avid, we do tend to treat them with radioiodine. So at follow-up, typically once the patient has been treated, put on radioactive iodine, so patient is called to follow-up for approximately about 6 months later. So one patient is asked to stop Eltroxin for about 3 to 4 weeks. Basically, we want the TSH to be more than 30 to 40. So patient comes to us for a large dose iodine scan. So we do thyroglobulin, anti-TG antibody, and TSH titers. And these are the three scenarios we expect to see. One, when there is good ablation, wherein we do not see any uptake in the residual thyroid tissue. Thyroglobulin is less than 2, so which is a good news for the patient, where it can restart L-Troxin and patient is on follow-up. Or in the second scenario, wherein there is partial ablation or the presence of metastatic disease, when thyroglobulin is elevated, then these patients would require another therapy. Third scenario would be one wherein there is absolutely no uptake, thyroglobulin is elevated. So unless proven otherwise, we would have to be looking at dedifferentiated disease in these patients. So these pictures demonstrate the true negative from the false negative. What is here on the left is true negative, wherein the scan is negative, thyroglobulin is also very well suppressed. So this is good news for the patient, whereas a false negative with an negative iodine scan with elevated thyroglobulin, which is when we would have to look for dedifferentiated disease. So coming to the role of TSH again. So some patients would not have elicited a sufficient TSH stimulus, wherein an iodine scan may be unable to demonstrate any uptake in the residual disease. So whenever your patients have an inadequate TSH response, that is when recombinant TSH is recommended, as in this patient. So what was initially this became this after recombinant TSH administration. So these patients tend to show good uptakes after administration of recombinant TSH and tend to have better outcomes. Again, recombinant TSH, once treated, because of the higher stimulation, better uptake is there in the metastatic disease, so that they have better outcomes. So we cannot treat these patients indefinitely. So there are criteria to define when radioiodine refractory disease is there. So basic criteria would be when there is no iodine uptake in the malignant metastatic tissue outside the thyroid bed on the first post-therapeutic scan. When iodine 131 uptake is lost after previous evidence of iodine 131A disease. Iodine is concentrated in some, but not in all other lesions. Disease progresses despite radioiodine therapy. Patient has received more than around 600 millicuries of radioiodine. And other potential criteria would be when you've done a FDG PET scan and you've seen more FDG-avid disease. So once a patient has qualified these criteria, that is when dedifferentiated disease is thought and an FDG PET scan is recommended. So before we treat these patients with, before we subject these patients to an FDG PET scan, an empirical radioiodine therapy is always advised, wherein we ensure that there is absolutely no stable iodide interference. We confirm that there is no extrinsic or intrinsic factor which could be interfering with our radioiodine uptake, and only after that would we be going ahead and labeling these patients as dedifferentiated disease. And FDG PET basically would be helping to detect and to localize locoregional recurrence or distant metastasis. And since we are looking at FDG uptake or glucose uptake, the higher the uptake means the more aggressive the disease is. So what are the options for these patients? Surgery, external radiotherapy, redifferentiated therapies, tyrosine kinase inhibitors, or other radionuclide therapies. So when we do FDG PET scan, as in this patient, we demonstrate extensive metastatic disease. If this patient had just local disease, then repeat surgery would have given him the best outcome. However, in the setting of metastatic disease, then only local therapies like stabilization or radiotherapy, ablations are what could be considered for these patients. Since we are talking of imaging, this picture is demonstrating as to which receptors are involved and where the isotope is localizing in the malignant cell. When we are talking of FDG imaging, what we are demonstrating basically is GLUT receptor overexpression in the tumor cell. And when we are talking of either gallium-68 DOTA8 or DOTANOX imaging, we are basically looking at somatostatin receptor expression on the cell wall. When we are talking of gallium-68 FAPI imaging, basically we are demonstrating tumor-associated fibroblast uptake. And when you're talking of PSMA scans, which are being done in a few centers, what we are basically demonstrating is tumor-associated neovascular uptake, showing PSMA uptake. So these are the few foci of uptake which are used to localize for dedifferentiated disease. So the options again for these patients, for most iodine 131 negative and thyroglobulin positive patients, if operable, then it's potentially curative. Or if a patient is non-iodine concentrating with a negative FDG PET scan, then these patients can be put on L-troxin suppression and surveillance. Or in a second scenario wherein this patient is non-iodine concentrating with a positive FDG PET scan, but disease is more or less stable, then a gallium-68 DOTANOX or a FAPI scan can be demonstrated to evaluate for expression of these receptors in a tumor. If there is high disease volume, then these patients can be treated with lutetium or actinium-225, DOTA8 or FAPI, depending on what the expression is. And basically, this is to reduce tumor volume. The third scenario, wherein it is tennis, FDG positive, and this patient is progressing despite everything. So these are patients who are typically put on tyrosine kinase inhibitors. Here also, when you are adding gallium-68 DOTANOX or a FAPI scan, and we can demonstrate uptake in these foci of disease, then again we can use lutetium or actinium to treat these patients to basically reduce tumor volume. And this is typically what it would look like. FDG PET scan showing FDG with disease here in the neck, showing somatostatin receptor expression. Similar patient who became non-iodine concentrating, treated with lutetium DOTA8. This patient had a good quality of life, survived for almost a year after therapy. So we can improve the quality of life for these patients. Cure, however, is definitely not possible. So when we are talking of dedifferentiation, these are the two hypotheses demonstrated, wherein with P53 and other genes, papillary or follicular moves on to become anaplastic. So redifferentiation therapies have been around in literature, wherein retinoic acid or HDAC or PPAR agonists have been recommended. However, in clinical practice, we have not seen any significant redifferentiation of tumors with these. However, now with the availability of this MAPK pathway inhibitors like selumetinib and dabrafenib, we are seeing a few patients who tend to redifferentiate. The next slide would be showing you that this was our patient. Again, he underwent surgery elsewhere, so treated with radioiodine. Subsequently, at follow-up, in the first follow-up, he had elevated thyroglobulin titers, but however, absent iodine uptake immediately in the first follow-up itself. So he underwent scans and subsequent transthoracic resection of a left paratracheal mass. So he had multiple lower cervical nodes also. So even after this, he underwent iodine scan, absolutely no uptake. He had lung metastasis. So since he was not iodine concentrating, he was put on lenvatinib. He was put on a high dose of lenvatinib, which he could not tolerate. So subsequently referred to us, underwent an empirical therapy with thyrogen. Even then, no uptake. So then subsequently, we got a BRAF mutation done for him. So he had a BRAF mutation. So following which he was put on dabrafenib, which he took for about 45 days. So surprise, what happened? What was initially this became this. So what was non-iodine concentrating became iodine concentrating after about 45 days of dabrafenib. So after this patient underwent radioiodine therapy, and what was this became this after therapy. So serial thyroglobulin levels, which were increasing drastically, came under control. So these are a few investigations and therapies available in nuclear medicine, which we are doing on a routine basis. You do have CT, MR, or ultrasound with you for all your investigations. However, the magical element here is nuclear imaging. Hope you do make good use of it. Thank you. Any questions, please?
Presentation. I have one question. Sometimes we see these patients who have undergone surgery 4 or 5 years back, and then they come without any radioiodine ablation, they come for follow-up. So do you advise that we should stop and do a thyroxine for a few weeks and do a radioiodine after 4 or 5 years if they present, or what will be your advice?
Sir, if it's already 4 or 5 years, if you have not seen any significant local recurrent disease, if thyroglobulin all along has been reasonably under control, then I don't think there is any extra role of radioiodine scan or therapy in these patients, provided the post-operative histology was favorable.
Thank you, sir. Any questions from the audience?
Tech
No,
team,
sir.
any question?
No, sir. Continue. Sir, continue, sir. Yeah.
Thank you very much.
Ma'am, shall we move to the next session, ma'am?
Yeah, we'll move. Yeah.
Yes, ma'am. Yes. Thank you, sir, for a very explicit and a very lucid presentation on this very much debated topic, in fact. So another short announcement before we proceed to the quiz. Those who are interested to submit their research to the flagship journal, that is the Thyroid Research and Practice, can do so by scanning the QR code which is displayed on the screen. And those who are interested to become a reviewer for the Thyroid Research and Practice, again, can simply scan the QR code. This will help you sign up as a reviewer. So, and now it's time for the much anticipated quiz. So before we start, a few rules and instructions. So click on the button, the attend quiz, which is present on the live stream screen. The quiz will be conducted via a platform called as Slido. The questions will be displayed for about 30 seconds time, each question. And the quiz has a total of 10 questions. So moving on, now I hand it over to Dr. Chitra Madam to introduce our quiz master, Dr. Harshita, who will guide us through the questions and answers. Okay. I think Chitra ma'am's mic is not working. So, ma'am, is it working now? Okay, okay. So, I request Dr. Pramila ma'am, if at all, if you can introduce Dr. Harshita. Dr. Harshita is madam's student, so I think ma'am can do
Yeah,
the.
she's yeah. Thanks, Ganvi. Dr.
Yes, ma'am.
Harshita is now a consultant, senior consultant, but yeah, she was our student and she has done her DM from our institute. And she's also the winner of TISA 2022. And she also got the RGHS gold medal for her DM endocrinology exam as well. So I hand it over to Dr. Harshita, and I think everybody has logged in for the quiz. So I hand it over to Dr. Ganvi. Yeah, and she can continue the proceedings.
Thank you, ma'am. Harshita, Dr. Harshita, I request you to start the quiz by displaying the questions on the screen.
Okay, ma'am. I think they should stop the slide sharing so that I can start it.
Yeah.
Ma'am, can you wait for more 2 or 3 minutes because only four members are there.
Ma'am, we'll wait for another 2 minutes before we start off with the quiz. Let's let everybody join. Yeah.
Okay, it's okay. That's okay. No problem.
Yeah. Bashir will give you the cue, ma'am.
Sure. Okay.
Please start, ma'am. Now it is 8.
Okay. Can I start?
Yes,
Yeah,
ma'am. Go
make
ahead.
it a slideshow, ma'am.
Ma'am, should we go ahead with the quiz, ma'am?
Yeah, we'll go ahead. We'll go ahead now. Yeah.
Yes, ma'am. Yeah.
Click on that play button, ma'am. Once.
Yeah, I'm actually doing that. Can I start?
Sham. Yeah. Yeah, Harshita, you can start.
Is it visible, ma'am?
Yes, ma'am. It is visible.
Just to click on play button, ma'am.
Where exactly is that? If you can guide
Fourth
me.
button from the left side on the top.
No,
Yeah. Left side. Left.
Yeah, left.
more to the right. The
No, to
fourth
the right.
button. Fourth
Yes.
button.
Yeah.
Next one.
Sorry, I'm not able to find it.
Next one. That's next to that. There is a play button. Yes.
Below. Yeah.
Yes.
Okay.
Yes. Awesome.
Can I start it, sir?
Yes.
Yes, ma'am.
Okay. As per Indian Thyroid Society guidelines, subjects with thyroid nodule with benign cytology, that is colloid nodule or thyroid cyst, are considered. Can you drag the box down, please, for me? Are considered true negative if they are followed up for a period of at least dash years. Option A, 1. Option B, 2 years. C, 3 years. D, 6 months.
Sham, you can give us the cue when to move on to the
Yes,
next
ma'am. Next,
question.
ma'am. Next.
Question 2. Which of the following is not a mechanism by which thyromimetics act to help in dyslipidemia? Option A. They cause upregulation of LDL receptors in the liver. Option B. They inhibit sterol regulatory element binding protein 1 in the liver. Option C. They inhibit cholesterol 7 alpha hydroxylase in the liver. D. They induce expression of ABCG5 and ABCG8 in the liver.
Next.
Question 3. Which of the following statements is true? A. Ultrasound has poor sensitivity in detection of cervical metastasis in patients with papillary thyroid carcinoma. B. Central vascularization is suggestive of lymph node malignancy. C. Lymph node with cystic appearance or hyperechoic punctation is suggestive of malignancy. D. Lymph node with hyperechoic hilum are considered malignant.
Next.
Question 4. A 37-year-old lady underwent total thyroidectomy and radioiodine remnant ablation for papillary thyroid cancer. Her histopathology shows classic variant of papillary thyroid cancer with no capsular or vascular invasion with no nodal metastasis. During her initial follow-up post-surgery, her serum thyroglobulin levels are 0.1 nanograms per ml. While starting her on levothyroxine therapy, what is her initial TSH goal in this scenario? A. 0.1 to 0.5. B. 0.5 to 2. C. Less than 0.1. D. More than 2.
Next, ma'am.
Question 5. All of the following are true about non-invasive follicular thyroid neoplasm with papillary-like nuclear features except A. Solid or trabecular growth pattern constitutes less than 30% of the histology. B. BRAF V600E mutations are very unlikely. C. Samoma bodies are not seen on histology. D. Well-formed papillae constitute less than 2% of the histology.
Next, ma'am.
Question 6. All of the following genes are associated with thyroid dysgenesis except A. NKX2, B. PAX8, C. JAG1, D. Duox.
Next, ma'am.
Question 7. A neonate undergoes DBS testing, dried blood spot testing at 36 hours of life. What is the recommended TSH cutoff in this case? A. 20, B. 24, C. 30, D. 34.
Next, ma'am.
Question 8. A 12-month-old boy presented with severe developmental delay, axial hypotonia, spastic quadriparesis, dystonia, and thyroid function abnormality, which is high free T3, low free T4, low reverse T3, and a normal TSH. What could be the most likely cause in this scenario? A. RTH beta, B. MCT8 deficiency, C. SBP2 deficiency, D. Resistance to thyroid hormone alpha.
Next.
Question 9. Which of the following is true about Graves' disease in children? A. Prepubertal onset Graves' disease has more favorable chances of remission. B. Remission rates in children are lower than adults. C. Eye signs are more common in children than adults. D. Radioactive iodine can be safely given to children below 5 years of age.
Next.
Last question. In levothyroxine malabsorption test, what is the cutoff of absorption that is used to rule out pseudo malabsorption? A. 40%, B. 50%, C. 60, D. 80%.
Sham, are we done with the time?
Yes, ma'am, it is over. Can I share you the screen for the?
No, just a second. Before we announce the quiz winners, we can share the answers. So thank you, Dr. Harshita, for leading such an insightful quiz. I request you to share the answer for today's quiz and also the MD quiz questions and later announce the winners for both the quiz.
Okay, ma'am.
Go on, Harshita. You can share the answers. You're on mute.
Harshita, we can't hear you.
Can you hear me now, ma'am?
Yeah, now you're audible. You can go ahead. Yeah. Just make it full screen and you can go ahead.
Yeah, sure. Okay, the first question, as per Indian Thyroid Society guidelines, subjects with thyroid nodule with benign cytology are considered true negative if they are followed up for a period of at least -years. The answer to this is 2 years. These guidelines were published in Thyroid Research and Practice in the latest issue. According to this, if we follow up a thyroid nodule for a period of 2 years, and it is considered true negative and we don't have to repeat an FNAC again. Coming to the second question, which of the following is not a mechanism by which thyromimetics act to help in dyslipidemia? The answer to this question is C. That is, they inhibit cholesterol 7 alpha hydroxylase is wrong. They induce cholesterol 7 alpha hydroxylase, which is the step in bile acid synthesis. Again, this question is taken from Thyroid Research and Practice. There is an excellent review article on thyromimetics here, published in the January edition of this journal, where you can see the effect of thyromimetics at various levels in controlling dyslipidemia and also in controlling NAFLD, and the pathophysiology is discussed in detail. I think this is a paper that we should go through. Moving on to the third question, which of the following statements is true? This is basically a question on ultrasound and its ability to detect malignancy. So the answer to this question is C. Ultrasound does not have a poor sensitivity as mentioned. It has good sensitivity. So option A is ruled out. Central vascularization is not suggestive of lymph node malignancy. It is peripheral vascularization. And coming to the option D, lymph node with hyperechoic hilum are generally considered benign. So the correct answer here, the true statement is lymph node with cystic appearance or hyperechoic punctation is suggestive of malignancy. Moving on to the fourth question, this is a clinical scenario where a 37-year-old lady underwent total thyroidectomy and radioiodine remnant ablation. Her histopathology showed a classic variant of PTC, which is considered to have good prognosis. There was no capsular or vascular invasion with nodal mets, and she came back with a suppressed, undetectable thyroglobulin levels of 0.1 nanogram per ml. So in this scenario, what is the levels at which we keep her initial suppressive TSH therapy goals? So the answer to this is B, which is 0.5 to 2. So these are recommendations from ATA guidelines for thyroid malignancy. In case of high-risk thyroid cancer patients, we keep the TSH to below 0.1. Intermediate risk, it is between 0.1 to 0.5. And for low risk, it is between 0.5 to 2. Since this patient falls under low risk category because of a suppressed thyroglobulin levels, a good histopathology with no vascular or capsular invasion, she falls under low risk and her TSH target would be between 0.5 to 2. Moving on to the next question. This is on non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which is the wrong statement in this. So this article, there is again a review article on the WHO 2022 classification of thyroid cancer in the latest journal, latest edition of Thyroid Research and Practice Journal. So if you see here, there are four. The right answer to this question is D. All the other three options are correct. In D, the cutoff is 1% of the histology, not 2%. So it states that in the presence of true well-formed papillae, even if it is less than 1% of the tumor can no longer be considered as NIFP and it should be considered as a malignant tumor and worked up accordingly. This is because tumors with papillae, they are associated with a high frequency of BRAF V600E mutations or lymph node metastasis or even distant metastasis. So even if there is well-formed papillae to less than 1% extent, then we have to rule out NIFP. Moving on to the next question, all of the following genes are associated with thyroid dysgenesis except. The answer is DUOX. All the other genes were associated with thyroid dysgenesis, whereas DUOX2 is the most common gene associated with thyroid dysharmonogenesis. Question 7. A neonate undergoes DBS testing at 36 hours of life, and what is the recommended TSH cutoff? So this is taken from ISPE guidelines. So the usual recommendation, we don't have cutoff specific when a sample is drawn between 24 to 48 hours of age. If at all for some reason a sample is drawn, Indian Society has given a cutoff of more than 34 to be taken in such a scenario for recall of such neonates for confirmatory testing. Question 8. A 12-month-old boy presented with severe developmental delay, axial hypotonia, spastic quadriparesis, dystonia, with a high free T3 and low free T4 and a normal TSH. What could be the clinical scenario? The answer is MCT8 deficiency. So it is an X-linked recessive disorder where there is a defect in the MCT8 transporter in the brain. So there is basically a hypothyroid state in the brain versus thyrotoxic state in the peripheral tissues. Because of this, the neurocognitive phenotype has severe intellectual, that is speech as well as motor disability as seen in our case. And there is peripheral thyrotoxicosis, which can manifest as low body weight and heart rhythm abnormalities. When we do lab tests, we see a classic picture of low T4, high T3 and a normal TSH. And Triac, which is a thyromimetic, is under trials as a therapeutic option for MCT8 deficiency. Which of the following is true about Graves' disease in children? The answer to this question is B. The remission rates in children are lower or poorer compared to adults. So it is not pre-pubertal, it is pubertal onset Graves' disease that has more favorable chances of remission. Eye signs are less common in children, and radioiodine therapy cannot be given to children below 5 years of age. The last question, coming to the levothyroxine malabsorption test, what is the cutoff that we use for pseudo malabsorption? The answer is C, which is 60%. So there is an excellent article in JCM last year, August 23, where they discussed in detail about levothyroxine absorption test. So as per this, the broad recommendations are that administer 1000 micrograms of levothyroxine in the patient's usual formulation as the test dose. So this is a debatable dose. Up to 500 to 1000 is the dose that has been discussed there. And ensure that the patient is supervised throughout the test because we are giving them a higher dose. Perform a 4-hour test. Hourly blood samples are taken, assaying the free T4 there. So consider that normal levothyroxine absorption corresponds to a free T4 increment of more than 0.4 nanograms per deciliter or a total T4 increment of more than 6 mics per deciliter for a test dose of at least 300 mics or a percentage total absorption of more than 60%. I think with this we'll conclude the DM answers. I would request Vijay Bhaskar sir to discuss the MD quiz answers. Thank you.
Thank you, Dr. Harshita. I'll just discuss the answers to the practitioners quiz which was conducted for this time ITS clinics. The first question was, as per the recent ITS consensus on salt iodization, the country is said to have achieved universal salt iodization, and at least what percent of households consume adequately iodized salt, that is 15 parts per million at consumer level. The answer is 90%. So in the recent issue of the Thyroid Research and Practice, we had an Indian Thyroid Society expert consensus salt iodization, clearly mentioning the target of more than 90% household coverage of adequately iodized salt. The correct answer target is more than 90% household coverage of adequately iodized salt. And at the consumer level, we want at least 15 parts per million. Next question was initial recommended lab test in the evaluation of thyroid nodule as per the recent Indian Thyroid Society consensus statement is ultrasound thyroid, thyroid nuclear scan, serum TSH, FNAC. The correct answer is serum TSH. In this recent issue of Thyroid Research and Practice Journal, we had this interesting consensus statement of the Indian Thyroid Society for Management of Thyroid Nodules, clearly mentioning that serum TSH should be measured during the initial evaluation of patients with thyroid nodule. If TSH is suppressed, then we do total T3 and free T4. And if T3 and T4 are elevated, then we do a scintigraphy. So we do not do a scintigraphy as the initial in imaging evaluation in patients with normal elevated TSH levels. Only for suppressed TSH levels, we do scintigraphy. So serum TSH is the initial test which is recommended for the evaluation of a patient with thyroid nodule. So name the curve depicting the natural history of thyroid eye disease. The correct answer is Rundle's curve, which depicts the natural history of the thyroid eye disease, wherein the active phase we give immunosuppressive therapy, and in chronic phase the immunosuppressive therapy does not work. Question 4 was all indications for T3 along with T4 except. So we can use T3 for symptomatic hypothyroidism when the TSH levels are normal, when we require swift reversal of symptoms, and secondary hypothyroidism not responding to treatment. Sick euthyroid syndrome, there is no indication to use T3 therapy. So for this also we had a good commentary on T3 in 2023, that is LT3, LTT4 combination, where they discuss about where it's useful, mainly for patients who have normalized the TSH levels and still they're symptomatic. We consider the use of T3 plus T4 combination. Next question was thyroid cancer not originating from thyroid follicular cells. The answer is medullary thyroid cancer, which the origin is from the parafollicular C cells and not from the follicular cells. The answer is medullary thyroid cancer. 10 milligram carbimazole is equal to what dose of methimazole was the sixth question. So a lot of times we have patients on carbimazole and methimazole. So it's useful for practitioner to know what is the converting factor. So 10 milligram carbimazole is equal to 6 milligram of methimazole. Next question is Dr. Prashant sir has discussed in detail about the use of nuclear imaging and radioisotopes in differentiated thyroid cancer. He clearly showed that the iodine isotope used for diagnosis and treatment of thyroid cancer is iodine 131. This question Dr. Harshita has discussed about the papillary thyroid cancer 2 years after the total thyroidectomy and post-op radioiodine ablation. So the answer is 0.1 to 0.5. 200 milligram amiodarone tablet contains how many milligram of iodine? The correct answer is 75 milligrams. The last question was the most common gene mutation thyroid cancer is in which gene? The correct answer is BRAF gene. Thank you. We can go to the prize winners.
Can I show the result for this quiz, ma'am?
Yes.
So I request Dr. Vijay sir and Dr. Harshita to announce the quiz winners.
Okay, so Harshita, you want to announce? So the DM quiz, the winner is Dr. Abhijit. Congratulations, Dr. Abhijit. And second is Dr. Neelam Yadav. And third winner is Yes, I think the name is not there in this. So yes is the third answer. Congratulations to all the winners. You will be receiving a appreciation certificate from the ITS through email. Next for the practitioners quiz.
The tech team, can we have the winners of the MD quiz?
Okay, so winners of the quiz conducted for practitioners. First prize goes to Dr. Pihu Agarwal. Second prize, Dr. Sudeep Kumar. And third one is Dr. Krishna Bhatt. Congratulations to all the winners. You will receive appreciation certificate from the ITS Tech team. Thank you. Thank you for participating in the quiz. Over to Dr. Ganavi.
Thank you, Dr. Vijay sir and Dr. Harshita, for an excellent set of quiz questions. So as we conclude today's session, I'd like to invite Dr. Pramila Madam to share her closing remarks.
So, yeah, thanks, Dr. Ganvi. And we really had a nice discussion today on the first, in the first session where Dr. Srinivasan discussed about the case of thyroid lymphoma and excellently moderated by Dr. Sridhar and Dr. Rajneesh Mittal. And then we had a very nice talk about by Dr. Prashant on the differentiated thyroid cancer. And we know that this is one of the areas where we always have doubts and we always have so many questions and diagnostic dilemmas. So that's a very, very important topic. And then the quiz, which was conducted by Dr. Harshita and Dr. Vijay Bhaskar Reddy, also participated. So we had nice questions, and I think the participants found it quite difficult because I was seeing the marks. It was the maximum. First person has scored only 5 correct out of 10. So I think our quiz was fine. So all the participants who have won, please put your phone numbers in the chat box, especially the third one, because we are not able to get the name, so that we know whom to send the certificate, because all of you will be getting the certificate from the Indian Thyroid Society for winning this quiz. And also, again, want to highlight that Thyroid Research and Practice is our journal, is the journal of the Indian Thyroid Society. So if any one of you want to submit your research regarding thyroid to this journal, you are most welcome to do that. We have an online system of submission of your research articles. So you can scan this, and the seniors who are already post DM and who are working and faculty, they are invited to join as a reviewer for Thyroid Research and Practice so that we can do a good peer review for our journal as well. So with this, I hand it over back to Dr. Ganvi and she can take it through.
Yes, ma'am. Thank you, ma'am. So we hope this session with discussion on the thyroid lymphoma, the nuclear medicine role in the management of DTC, and the quiz questions, which were mostly focused on DTC, has been valuable and informative. So our next thyroid clinic session is scheduled for Jan 8th. Of 2025. So we are eager to host you once again for a session which is rich in knowledge and insight. So with that, we conclude. Thank you, everyone.
Good night.
Good night. Good night, ma'am. Yeah.
Tech team, we are not online, right?
तस्य भासः सर्वमिदं विभाति